Welcome back to our EKG learning series, and today we will talk about ST segment elevation. Now, we always, when we see ST segment elevation, we will think about myocardial ischemia or infarction, which is actually the most important cause of the ST segment abnormalities, right? But we have to know that we have multiple other causes that can give us ST segment elevation as well. So you have to think about the patient symptoms and some features of the ST segment elevation to properly identify what is the diagnosis. So what is the ST segment? ST segment is actually the flat isoelectric portion or section in the EKG between the J point at the end of the QRS complex and the beginning of the T wave. It represents, as we know, it represents the interval between ventricular depolarization that is seen as a QRS complex and the ventricular repolarization, which is the T wave. And as we said, the most common or the most important cause of ST segment elevation or depression is actually myocardial ischemia. But we have to think about other causes of ST segment elevation. Number one is acute myocardial infarction. This is the most important one. Number two, you have to think about pericarditis as well, or coronary vasospasm, which is the brain's metal angina. Left bundle branch block and left ventricular hypertrophy, both of them can give us ST segment elevation as well. If we talk about ventricular aneurysms as well and ventricular paced rhythm, both of them can give an ST segment elevation on the EKG. Brugada syndrome also is a cause. Raised intracranial pressure because of the increased sympathetic outflow from the brain stem to the heart. And benign early repolarization, this is very important because we will talk about it briefly. And the Takotsubo cardiomyopathy as well is a cause of ST segment elevation. So all of them can present as STEMI, which is ST segment elevation MI. So how to differentiate between all of them? You have to understand that EKG is not interpreted by itself. You have to understand what are the patient's symptoms, and the same and what is the troponin level and other biomarkers, and accordingly you have to interpret your EKG. I will talk about specific tips here for the ST segment elevation, and for the other causes we will discuss them in different videos. All right. For the STEMI, for a patient to have a STEMI, which is ST segment elevation MI, the ST segment elevation should be in contagious leads. That being said, if the ST segment elevation is in V1 and V2, remember that these two leads are looking at the septum of the heart, so you have a septal infarct. If the ST segment elevation is in V3 and V4, they are looking at the anterior part of the heart, anterior wall, so the patient will have anterior infarction. Lateral leads, which are the lead 1, AVL, and V5 and 6, they are looking at the heart at the lateral side of the lateral wall. So if the ST segment elevation are found in these leads, you have to think about lateral ischemia. Inferior, they are very important. Lead 2, 3, and AVF, they are looking at the heart from inferior at the inferior wall. And right ventricle. So sometimes, guys, if we suspect that patient has a right ventricular ischemia or right ventricular myocardial infarction, we place a new lead that is called V4R, which is the same V4 that looks at the anterior wall of the heart, but we put it at the right side at the 5th intercostal space. And if this lead will give, if the patient has a right ventricular infarction, it will give us a ST segment elevation there. And V1 as well, because it's looking at the septum and it's placed on the right side of the sternum. So it can give us an idea about the right ventricle. Posterior infarct, if the patient has a posterior wall infarct, if you suspect this, you will put 3 new leads, V7, V8, and V9 on the back of the patient, and they will give us a ST segment elevation. There is another feature along with the ST segment elevation that signifies STEMI. As I told you, the contagiousity of the leads, this signifies STEMI by itself. Okay, but the most important part here, if you have a reciprocal ST depression. So, for example, if a patient has an inferior myocardial infarction in lead 2, 3, AVF, and these 3 leads are showing ST segment elevation, we suspect that the anterior leads, V3, V4, and even lateral leads, because they are reciprocal, they are the opposite direction of the inferior wall, they will have ST segment depression. The same thing is with the posterior infarct. The posterior infarct, V7, 8, and 9 will have ST segment elevation. But if you look at the heart anteriorly, which is the opposite side of the posterior wall of the heart, V1 and V2 will show ST segment depression. So this is very important, and this will support the diagnosis of STEMI. Let's have an EKG here and look at it. If you can look at this EKG, I will give you like 3 seconds to think about where is the ischemia or where is the ST segment elevation. As you can see, of course, you can pause the video as well to think about it. You can look at lead 2 here. You can find that ST segment is elevated. This is the isoelectric line, and it's elevated above the isoelectric line. The same thing in lead 2 and lead 3 as well, as you can see here, and lead AVF. So they are contagious leads, right? They are very, the three of these leads are looking at the heart from the inferior wall, right? So this is inferior MI. That being said, this will be supported with ST segment depression on reciprocal leads, which is the anterior leads. So if you look at the V2, you'll find depression here. V3, depression. V4, some depression as well. And even AVL, you have some depression, which is the lateral wall, which is opposite to the inferior wall as well. So this reciprocal depression also supports the diagnosis of STEMI, which is the ST segment elevation like cardiac infarction. All right, let's talk about another cause here, which is the acute pericarditis. Now, acute pericarditis also will give us ST segment elevation, but it will be widespread, meaning that almost all the lead, if not almost of them will have ST segment elevation. So it will not become in contagious leads only. It will come in almost all the leads, along with PR depression. Let's look here. So if we look at lead 2, there is some elevation, as you can see here, because here is the isoelectric line. And there are PR depression. If you look here, the PR wave is a little bit depressed. The same thing is seen in lead 3. The same thing is seen in AVF. If we look also here in lead V4, there is elevation here with some depression here. V5 is the same thing, okay? And even V6, not that much. So they are not contagious leads, right? So you have to think about pericarditis. And even V2 as well, we can see some depression without, some elevation without depression. Oh, V3 is also elevated, as you can see here. Okay, and with some minimal depression here. So you have to think about pericarditis on those patients. All right. So as we said, acute pericarditis, multiple, if not all leads will have the same problem, the ST segment elevation. All right. The other cause is coronary vasospasm. Coronary vasospasm or Prinzmetal angina is a very important cause because the patient will present with severe chest pain, intermittent chest pain, and you will do an EKG and you will see the ST segment elevation. And actually, guys, there is no way that it is very impossible to differentiate Prinzmetal angina from STEMI, ST segment elevation. They give you the same pattern because in coronary vasospasm, the coronaries are vasospastic, they are closed, and the blood supply is cut on the heart, and the muscle is suffering, right? So the ST segment will be elevated with the same reciprocal changes even. So what is the difference? You have to look at the clinical context of the patient. Usually the patient will be younger, and number 2, the troponin will be negative. Okay, the troponin, because it's still an angina. Okay, you have to think about this. So the pattern of ST segment elevation here in Prinzmetal angina is very similar to acute STEMI. And it is impossible to differentiate these conditions based on the EKG alone. All right. The other cause of one important thing that I want to stress is the benign early repolarization. Well, this is actually a normal phenomena in which there is early repolarization, meaning that the T wave will become very early. Okay, this is seen and this is a very normal variant, commonly seen in young, healthy patients with no other comorbidities. And you will see that when you do an EKG for any other reason, you will find, without chest pain, of course, you will find some ST segment elevation. This ST segment elevation is almost always coming with tall T wave. The T wave will become tall because the repolarization is happening earlier. Okay. The one important characteristic here is this notch, as you can see it here. There is a small notch at the J point. This small notch is called fish hook pattern. Okay, this is a benign phenomena, meaning that the repolarization is happening earlier in the course, and the T wave will be peaked as well with this. All right, for the other causes of ST segment elevation, they will be discussed in other videos specifically for those causes. So these are my tricks and tips for ST segment elevation, and thank you.